Welcome back to the Living Well podcast. I'm Jessica Lopez, and today we're talking about weight loss, metabolism, and bariatric surgery with an expert who is a national leader in the surgical treatment and management of obesity, Dr. Ramsey Dallal. We'll dive into why losing weight is so hard for so many people and how bariatric surgery might be an option for those struggling with obesity.
We're also going to get into the science behind metabolism, the role of hunger, and why diet alone doesn't always cut it when it comes to managing weight. Plus, we'll talk about how surgery can actually change your relationship with food in a way that makes it easier to stick to a healthier lifestyle.
With that, here's our conversation with Dr. Dallal.
My name is Ramsey Dallal. I've been at Einstein and Jefferson for now almost 20 years, and I'm the enterprise physician lead for bariatric surgery.
Can you share insights into the primary factors that make it difficult for individuals to lose weight and keep it off?
Well, in truth, the fallacy is that losing weight and keeping it off is normal or what most people are capable of doing. The truth is, most people are incapable of losing substantial weight and keeping it off. That is the norm. The pictures, I'm old now, I would say, People magazine before and after covers are abnormal. That is the extraordinarily rare event. And the problem is we promote that in our society as being a normal result of dieting, that everybody who fails at it thinking that they are the abnormal ones. I guess now it's Instagram and TikTok before and afters. We are not designed to live in today's environment when food is ever present, when it is designed to be high in calories and provided in large quantities, when food is much cheaper per our income level than it had been in previous decades. So we don't have to work hard for food. Food is designed now to be health poor, and we have never lived in an environment such as this in our human history. 100 years ago, there was hardly anybody who suffered from the disease of obesity. Today, we have 60% of America who may be considered obese. Our genes didn't change in 100 years. There may be those who have a hereditary or genetic predisposition to being overweight, but that never cropped its head until we are now living in an environment where food is ever present. So the one big factor is, of course, there's a genetic predisposition, but the biggest factor is our environment is different. Now, are there physiologic basis for this as well? Of course. Our bodies decrease their metabolic rate when you are dieting, so you need less and less food the lower and lower weight you are, and it makes it much more difficult to continue to losing weight. In addition, as you lose weight, you get hungrier, so the willful requirement to withhold calories becomes more and more difficult, and it takes a whole lot less calories to regain the weight that you've lost because your body is in a survival mode. It thinks it's starving because it thinks we're born in the 1500s where food was rarely present and there may have been famine or rare events that occurred that made food difficult to obtain, and your body's like, well, we need to be really good. We don't know when the next food will be available, and so we're going to decrease your metabolic rate. What I'd like to portray to people is that it is normal for it to be difficult to lose weight. It is not normal to lose 100 pounds on your own and keep it off and it'd be easy. People come to my office all the time saying, well, why me? What is different about me? I have difficulty losing weight, or I can lose weight and only happens fleetingly and I gain weight right back up, and then something is different in my body. And the truth is that's not true. Your body is acting like everybody else's body, and you're not the abnormal one. You're the normal one. Once we start treating obesity as a disease instead of a personal weakness, we can start looking at true treatments and open up the possibilities for patients instead of them believing every day that it's something they did wrong, it's their fault, that they're weak-willed, society's biases drive into them and just make them feel terrible about themselves every day. And that's what's wrong.
when it comes to how metabolism works and how it can affect weight loss. Can you talk about why some people may find it harder to lose weight than other people?
Actually, people have this false belief that a person who is heavier than another person who may be lighter may have significant different metabolisms. So let's say on average, a person should be having 2,000 calories a day. And yes, if you're overweight, you're eating slightly more than you need over a very long period of time. What's fascinating is if you had an identical twin sister, brother, and that identical twin had never been overweight in their life, and they're 5'4", 125 pounds, and you're 325 pounds, and you do an amazing job on your own, being very mindful with your eating, and now you've lost 200 pounds. And now you weigh exactly the same as your identical twin sister. You know what the sad part is? For the rest of your life, you will have to eat less than your identical twin sister in order to maintain the same weight. And it's not even slightly less, it's substantially less, even though she's your identical twin. Because your body's metabolism has slowed down. And instead of requiring perhaps 2,000 calories a day to maintain a weight, you now have to maintain a 1,200 calorie a day diet. And that is just really difficult, especially when a bagel goes 500-600 calories these days. The more you lose weight, the more willful you have to be. The more you lose weight, the less calories you can eat before you start gaining. And everybody experiences this who's ever tried to lose weight. This like rings the bell of truth. You're like, yeah, that's what happened to me. So it has nothing to do with being weak-willed. It has to do with how our human bodies respond to calorie deprivation. What I find fascinating is every part of your body has this balance system. If your blood pressure goes high, your body knows how to drop it. If the blood pressure goes low, it knows how to raise it. If your sodium level goes high, it can lower it. If it goes too low, it can raise it. Your thyroid level goes too high or too low. Everything has a plus minus balance that keeps things regulated. The body actually has no way to know how heavy it is. There's only, I am hungry, I am losing weight, I must gain it. Somebody who's 300 pounds gets just as hungry as somebody who's 120. You would say, well, the body's 300 pounds. They should know not to get hungry anymore. Shouldn't there be that balance? I'm not hungry anymore. I got enough to store for a few weeks. It doesn't happen that way. They get just as hungry. And so there's not that negative feedback that says, hey, guy, you don't really need it. You've stored it. You can lay off. That doesn't happen. What's fascinating is it happens in every other part of our body's regulation. And that's because, likely, historically, obesity never existed as a disease. We did not have to create that safety mechanism in the past. People weren't 300 pounds in the 12th century. That didn't exist.
And that kind of leads us to our next point. So when does bariatric surgery become a viable option for someone struggling with obesity?
That's a nuanced answer because, in truth, a whole lot more people qualify for surgery and would benefit from it and have an improved health and quality of life and life expectancy than utilize it because people are fearful. People are ashamed. They're embarrassed. They think it's the easy way out. Society is telling them it's their fault. And so the barrier isn't, do I qualify? The barrier is, let me recognize this as a disease that has a surgical treatment that will improve my quality of life and health. Mm-hmm. And the public still does not see obesity as a disease, and thus there is societal bias against even thinking about it as an option. You would go to your surgeon because you need a hip replacement and your hip is killing you. And you are told, if you get a hip replacement, you'll be able to walk. And you're excited. You're like, I can't wait to get this hip replacement. And you tell your family, I need a hip replacement. They're like, yeah, we're going to support you. But you're limping down the hallway, carrying a bag of your medications that you just filled out for high blood pressure and diabetes. And you got the CPAP mask in your bedroom, and you go to your family member and say, my doctor says that if I have weight loss surgery, that I may not need these medications and the CPAP machine, and my hip may feel a lot better. I may not need a replacement. And the family responds by saying, we love you how you are. And that is because society tells you that it is your fault that you're obese, that you have a weight problem, it's a mental disease, that you just have uncontrolled hunger and you just need to try harder. And so people then don't seek help that would benefit from it. The technical answer to your question is if you're about 75 to 100 pounds over your ideal body weight, depending on your medical conditions, you're a candidate. And that ideal body weight is that crazy chart in a Metropolitan Life tables that you're like, there's no way that's an ideal body weight. I would say a 5'4" woman should be 120 pounds. That means somebody who's 200 and 220 pounds, depending on their height, medical problems, should be a candidate and could benefit. And we do surgeries because the benefits outweigh the risks. And what's happened is the risks of these surgeries have decreased dramatically over the years based on the minimally invasive techniques we have. And the benefits are dramatic in terms of life expectancy and decreasing medications and heart and other conditions.
And can you go into a overview of what are the different types of surgeries? I think people think of gastric bypass, and there's also sleeve gastrectomy, and a little bit about how they work.
Yeah, okay. What's fascinating about how they work, because they all work similarly. They work by decreasing hunger. They work by decreasing cravings. They work by making you feel satisfied with much less food. Because we said that weight gain occurs because your hunger increases dramatically, and it's hard to maintain that willfulness. But if you don't get hungry in the first place, it's a whole lot easier to lose weight. And what that teaches you is that people are not overeating because they have a personality disorder. I didn't operate on them and change their personality. I operated on them and changed their hunger, changed their relationship with food. People who had been given diagnoses of binge eating disorder, emotional eating, nighttime eating, whatever diagnosis you want, regardless of the label, after these operations, they don't feel driven to eat. Food is no longer important to them. Before surgery, some say, oh, I'm going to miss this or that. And after surgery, people say, I didn't even care. Why did I even think I would miss it? It's a profound change in behavior that occurs because we're changing the nerves and the hormones that are involved with regulating appetite, regardless of which procedure you choose, because they all work similarly, the sleeve gastrectomy, the gastric bypass, and other operations. Of course, the operations all work by decreasing the size of the stomach so you feel full quicker after you eat. But if that's the only way it worked, you'd just be starving all the time, and that would be miserable too. You'd just be eat and you're full, but now I'm starving again, eat, I'm full, I'm starving again. But what happens is you just don't even care to eat anymore because it's just not important. That's the main way they work, and it's a profound way they work. And the differences in weight loss between the operations are minor, but in general, the reason why there may be differences is some operations are a little bit better at suppressing appetite than others.
And along those lines of losing your appetite, where do the weight loss medications fit into the weight loss surgery? Is that something that people would do before or after the
So
procedure?
cool. We're living in a great time. These medications are fantastic. The reason why these medications came to be were because they saw what happened with various hormones after bariatric surgery. So they're trying to replicate that response with medication. God forbid you have cancer. There are multiple treatment options. There are multiple different types of chemotherapy, radiation, or immunotherapy these days, and surgery. And depending on the cancer, depending on where it is, what kind it is, there may be options that include multiple treatment modalities. What I'd like to emphasize, it's not either or surgery or medications. It's not either bypass or sleeve. The idea that we have multiple options is great for patients. Some patients, and I may see, may be extraordinarily sick, and if I can get them to lose a little bit of weight before surgery, maybe the surgery will go smoother and better. And maybe I put them on medications ahead of time. And then by the time they get surgery, because that always takes a few months to get going, they may be optimized to have a more safe operation. Some patients do amazing with just medications alone. Some patients after surgery, we haven't quite met their expectations and goal, and we may put them on medications afterwards. So it's not an either or. It's a look at this armamentarium we now have of medications and surgery to treat a terrible disease, which is robbing people of their lives, their quality of lives, their ability to play with their kids and their grandkids. And now we can use all these methods to optimize an individualized treatment.
And I'm wondering, we had a question about how someone would know if they're a good candidate for weight loss surgery. Is it really just if you're in that 75 to 100 pounds overweight category? Are there other criteria that you use to determine?
There are a number of criteria. Of course, there's a weight criteria, often using BMI greater than 40 or between 35 and 40 with medical conditions such as hypertension, diabetes, or sleep apnea. But those aren't even cut in stone. There's always some leeway back and forth. The sicker the patient is, in my mind, the better the candidate, because the more they have to gain from losing weight. Some people are fearful. Well, I have heart disease. I have heart failure. I have a heart stent. Some people, oh, I had a stroke. Oh, I have terrible diabetes and my kidneys are maybe failing. Those are great candidates because these operations prevent a heart attack and they prevent stroke and they prevent progression of kidney disease and they reverse or make diabetes so much better that the complications of diabetes are less. So while we certainly get the 20-year-old who may not have yet developed medical problems and whose biggest complaint is that, I don't feel comfortable, I can't fit in society well, I'm maybe discriminated against with jobs and work, and my knees really hurt, I can't get around, that's a valid reason to have surgery. But it's also a valid reason that you're 60 years old and you're afraid you're going to have a heart attack and stroke or cancer, and we want to prevent those from occurring so that you can participate in life and not be worried as much about your health.
And what can patients expect in terms of like recovery time, diet adjustments, and long-term lifestyle changes after surgery?
It's a great question because a lot of people are fearful. One, before surgery, they were like, I really want to do a good job. I've failed many diets before. I'm not going to fail this one. I am going to follow things to the mark, right? But in truth, they forget or they don't understand that the surgery does so much for them. So in terms of what lifestyle modifications are necessary after surgery, there are some, but you also have to trust the surgery makes it easy. If I told you what the post-surgical diet is, you're like, well, what's the difference between that and Weight Watchers? Well, that's somewhat valid, true. But the difference is it's easy to do the diet because that's all you want to do and you can't do any more. When I say, oh, you're going to be on liquids for a few days, then you're going to be on soft foods for a couple of weeks and, slowly introduce solid foods over a few months, people were like, wow, that sounds hard. But after surgery, that's all you can do or want to do. And you're not feeling deprived because that's all you can do. In terms of physical recovery, it's remarkable. I operated on an anesthesiologist not long ago, and he was back to work doing 12-hour shifts 4 days later. So while there is, in some, pain and discomfort for a short period, a day or two, that usually resolves very rapidly. Some people feel fatigued and tired for a few days, a week. Some people don't. Some people feel gassy and bloated for a few days, but slow drinking the first few days, but it quickly improves. So you're doing a 45-minute operation with an overnight hospital stay and getting people back to work in a week's time. And for that, you're getting in return an increased life expectancy, an improved quality of life, decreased medications, and now going to the doctor's office, hearing good news every time instead of being fearful of what bad news you're going to get.
And in terms of other lifestyle changes that need to happen in order to be successful in weight loss and management, being active comes to mind. Like, are there other things?
Of course, improving activity and exercise decreases blood pressure, improves blood sugar, improves strength, decreases frailty, does so many good things to your body. Now, in truth, 30 minutes of exercise a day, every day, has not been associated with significant weight loss. Why is that? Well, I mean, that may be 200-300 calories of work spent. People get a little hungrier. They want to reward themselves for the workout they just had. It ends up being a wash. Mm-hmm. While exercise after surgery is very helpful for a person's health, there are quite honestly some people who have difficulty doing it. They may have 2 jobs, 3 kids. They may have medical illnesses that make significant exercise difficult, immobility, chronic pains. So I want to emphasize that exercise is helpful, but I don't want to overemphasize exercise as the main problem of obesity. The problem of obesity is the diet, it's not the exercise. Exercise helps, but I've operated on people who are quadriplegics. They have a spinal injury, they cannot move from the neck down, and I do bariatric surgery on them, and they lose hundreds of pounds. So the diet is the most important part of the weight loss. The exercise is important for your health, we encourage it, we help it, we individualize plans. But if for whatever reason you're incapable of exercise, it doesn't mean you wouldn't benefit from these operations, because the majority of weight loss is from your diet.
And is there anything else that you think people should know or understand about bariatric surgery that hasn't come up?
The biggest thing is people are scared. They're scared to have surgery because it sounds invasive. And again, I'm biased. I'm a surgeon. I do this every day. I don't want to belittle the fact that it is invasive. It's surgery. What I would have people keep in mind, doing nothing is often scarier. I wish you didn't have to come to my office and this wasn't a problem and you didn't need help. And yes, while science has progressed and the risks are pretty small, they're not zero. I'm not going to tell you they are. But don't forget, the risks of doing nothing are far greater. And it's not just, again, health risks, it's quality of life risks. The important thing for a patient is to feel comfortable with the group of surgeons in practice that they are meeting with, to know that they will be taken care of. Often people will come and see me because their fear of doing nothing becomes greater than their fear of surgery. I can pretend all I want to that this should be a logical decision, that you should just put check boxes in the plus and the minus column and be able to compute the right answer. But we're not computers. We're humans with feelings and emotion. I understand why people should be fearful of having to see a doctor and undergoing and talking about surgery. But keep in mind, there's a downside of not doing something. In 10 years, are you going to need a cane? In 10 years, are you going to be on less medications or more? In 10 years, are you going to be able to chase after your grandkids? In 10 years, what are the complications of diabetes that you're going to end up having to deal with?
Mm-hmm.
And could they have been all avoided if I had done something today?
Be sure to check out the show notes for additional resources, including a link to the Living Well blog where we publish full episode transcripts.
And as always, if you enjoy our podcasts, we truly appreciate a rating on Apple, Spotify, or wherever you listen to podcasts. The full podcast episodes are now available on our YouTube channel at Jefferson Health.
Production support for today's episode provided by Brittany Rafalek and Barbara Henderson. We're your hosts, Jess Lopez
and Carly Williams. Be well.